From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome. This is Dr. Eve Rittenberg, the Viewpoint and online editor at JAMA Internal Medicine. Today we're talking about a study of lung cancer screening. So how many eligible people are up to date with the screening that's recommended, meaning annual low-dose CT scans for people at high risk? So as a primary care physician, I know that lung cancer screening is a place where prevention can make an enormous difference. Lung cancer is the leading cause of cancer death in the United States, and earlier stage diagnosis is clearly associated with improved survival. But most high-risk people don't get screened. So today we'll dive into that gap in care and how it might be improved. Our guests are Dr. Priti Bandi, the first author of a study titled Lung Cancer Screening in the United States, 2022. Dr. Bandi is the Scientific Director of Cancer Risk Factors and Screening Surveillance Research at the American Cancer Society. Dr. Bandi and her co-authors found that fewer than 1 in 5 eligible adults report being up to date with lung cancer screening, and that this rate varies more than threefold among the different states in our country. So I'm eager to hear her tell about what she found. And in addition, we're going to hear from Dr. Ilana Richman, who co-authored the commentary, Adoption of Lung Cancer Screening in the United States, What Will Success Look Like? Dr. Richman is an assistant professor at the Yale School of Medicine, whose research explores preventive breast and lung cancer screening services. Today, Dr. Bandi and Dr. Richman will share with you the findings in the study and then discuss their thoughts about how to get to a better and more equitable implementation of lung cancer screening in the United States. So a warm welcome to both our guests. And I'll start with you, Dr. Bandi. Can you tell us why you did this study?
First off, thank you for having me here. So lung cancer continues to be one of the leading causes of cancer death in the US. In 2024 alone, we expect more than 125,000 deaths from this disease. As you mentioned, we know that an earlier detection of this disease is associated with a markedly better survival. But unfortunately, more than 40% of cases are diagnosed at a distant stage, where relative survival, 5-year relative survival, is just a dismal 8%. So in this regard, in 2014, the United States Preventative Services Task Force, or the USPSTF as we commonly call it, recommended lung cancer screenings for the early detection of lung cancer on evidence that, annual screening with low-dose computed tomography is actually relatively more beneficial than a chest radiography. And since then, the USPSTF has gone on and most recently in 2021 to update their recommendation to increase the population who are eligible for screening by lowering the age of starting screening and reduce the pack-year smoking history eligibility among high-risk individuals. Now, fast forward a decade, we're here in 2024. We actually know very little about what the uptake of lung cancer screening is among eligible US adults. And tracking of population screening levels is important because it allows us to identify where the gaps are in terms of utilization of screening and potentially subsequently target appropriate efforts for improving uptake. And the reason why we were not able to track lung cancer screening so well in the past is that these large national and state-based surveys that we typically use to track screenings have not included lung cancer screening as one of the questions with much regularity. In 2022, however, this changed when the Behavioral Risk Factor Surveillance System, this large state representative nationwide survey, administered lung cancer screening questions in all 50 states and US territories, allowing us for the first time to conduct a nationwide assessment of the population uptake of lung cancer screening. So a couple of different reasons came together for why we did this study.
It was really interesting to me that some of your findings, I think, can be used to start getting a sense of the reasons behind variations in lung cancer screening rates. So wondering if you could tell us a little bit about what you found in your study, and then we can think about what those findings might mean.
Sure. We identified about 26,000 respondents who were eligible for lung cancer screening. This translated to a weighted population of about 13.17 million individuals. And of these eligible individuals, about 2.17 million, or about 18.1%, reported being up to date for lung cancer screening in 2022. So overall, lung cancer screening remained low in the eligible population. About less than 1 in 5 individuals who were eligible were screened according to recommendations. And in terms of differences according to respondent characteristics, the most marked disparities we saw was by healthcare access. So just 4% to 5% of individuals who were without insurance or without a usual source of care received recommended lung cancer screening. And the highest rates according to insurance were among Medicare insured, where about 26% were receiving these screenings. We also noticed a very interesting age gradient in lung cancer screening, where those who were the youngest assessed age of 50 to 54-year-old, they were 75% less likely to be screened compared to the oldest age groups, right? 70 to 79-year-olds, whom the prevalence was 27%. And interestingly and possibly related, we saw that there was also a gradient of increasing screening prevalence with increasing comorbidities. So those who had 3 or more reported comorbidities had a screening rate of 26%, almost 3 times higher than eligible respondents without a comorbidity. Now, in terms of the geographic state-level differences, we observed a wide threefold variation in screening rates, from a high of 31% in Rhode Island to a low of 10% in Wyoming. And importantly, we found no correlation really between lung cancer mortality burden and lung cancer screening rates. And this pattern was particularly apparent in southern states where there was a really high mortality burden, but the lung cancer screening rates were lower than the national mean in almost all of these states. And on the other hand, in northeastern states, lung cancer mortality burden was low, but screening rates were higher than average. And so essentially there was this discordance between lung cancer screening need in terms of the burden and the actual uptake of lung cancer screening, at least geographically. And finally, we observed a strong and positive relationship between Medicaid expansion status and state-level screening capacity and its relation with lung cancer screening rates across U.S. states, pointing to at least a few state-level policy or implementation factors that could be worked on to improve screening levels.
Priti, your findings raise so many questions for me. So I'm actually going to turn it over right now to Ilana to help us understand some of those issues and the barriers to lung cancer screening, and then think about what some strategies might be to address those barriers. Dr. Richman.
Thank you. And thank you for having me too. There's been a rich qualitative literature exploring barriers to lung cancer screening. And I think one of the reasons why Priti's study is so nice is because it provides an excellent quantitative view of some of the barriers that really complements the qualitative literature. So one of the themes from the qualitative literature that really comes through is that there's no single answer about why lung cancer screening is low. There are barriers at every level, at the level of the patient, the clinician, the health system, and broader societal level or community. And I think we see evidence of some of those barriers in this study. So thinking about the community level, right, we see wide variation across states, which suggests there's something about that state. Is it the environment, the culture, the resources, state level policies, but something that is bigger than just an individual, right? It's at the level of the state. Supporting that is that there's clear evidence of policy effect. States that have expanded Medicaid were more likely to have eligible patients screened, right? So we see direct evidence of a policy effect, which may drive some of these state level differences. There are also individual level differences. And I think the data around age and comorbidity are a really interesting example of how individual level factors matter. What is it about age? What is it about comorbidity? Particularly, right, since we think that there may be an inverse relationship between comorbidity and benefit of lung cancer screening. Why is it that people with more comorbidity get screened? Maybe it's more contact with the healthcare system, more trust in their physician. All these things really could matter. So I think we see all these levels at play, and it really speaks to the complexity of trying to implement lung cancer screening.
So interesting. We do try to take from our studies and our commentaries some tips or useful pearls for our audience. And I wonder if, as you look at the barriers and potential strategies that work to improve lung cancer screening, if you have some tips for those of us who work with patients who might be eligible for screening but have not yet been screened.
Sure, I can try to tackle that. Well, I think the state level data points to how powerful environmental factors might be. Now, exactly what is the secret sauce from state to state isn't totally clear, but there are examples from states that have made concerted efforts to make lung cancer screening much more integrated and the norm. And so doing things like academic detailing and raising awareness among clinicians, providing CME to help people get up to speed on lung cancer screening. So really building up capacity on the state level can be really powerful, as opposed to relying on the clinician to just remember, during a busy clinical encounter. So doing, I think, everything we can to create the conditions for success in a concerted way is really important. There are other ways maybe of thinking about that too. Like there are examples from the behavioral economics literature of changing the default. For example, can we make lung cancer screening something that we think about in every visit because it's there waiting for us? So how can we change the conditions to make lung cancer screening a lot easier? And I think that's going to be really important in thinking about how to integrate this better into primary care.
Yeah, just tying into what Ilana just said, I mean, the findings from this, the main finding, one of the findings from this study is that screening rates remain arguably low, right? And there obviously, like she mentioned, there are multi-level factors that go into why it has remained low a decade after screening was recommended, and as mortality benefits, at least from trial settings, have accrued, the evidence has started to accrue. Now, for better or worse, primary care providers, including internists, they play this role of gatekeepers, so to speak, in whether a patient receives screening or not. And this is true even for lung cancer screening. And to that extent, I think provider recommendation to get screened can go a long way in actually a patient receiving or taking up screening. But it seems like a no-brainer, but the evidence, and Ilana alluded to this, the qualitative literature shows time and again that patients report a provider not recommending it as being the reason that they were not screened. And this is something that we've also shown with population-based surveys. For example, a study of ours showed that among those persons who were overdue for colorectal cancer screening, almost 70% reported among US adults that they had not received a provider recommendation to get screened. So to that extent, a provider recommendation would go a long way, but obviously it has to be institutionalized in a way where it's not up to a provider to think of and ask this or assess the eligibility, but almost becomes de facto. So that was one thought I had, and I really want to make a plug for prevention here with an encounter for lung cancer screening. A large majority of those who are eligible are still currently smoking, and we still have the opportunity to prevent lung cancer in these people. So smoking cessation counseling and treatment is going to be essential for internists to incorporate into their encounter. So that was just a few thoughts I had.
Thank you so much for adding that to sort of round out the prevention, that lung cancer screening and prevention is not just the CT scan, but it is also the conversation around smoking as well. Really appreciate that. And also for folks to think about what they're able to do on an individual level, and also think about the societal or systemic or statewide policies that are key to improving screening rates. So putting that into context. Thank you both so much. There's so much here. We could talk for another hour, but we have to end this podcast. I really appreciated talking with you both. Thank you for joining us today. This is Dr. Eve Rittenberg, the Viewpoint and online editor at JAMA Internal Medicine, and I hope you've enjoyed this podcast. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com, and thank you for listening.